So with that, I would like to introduce today's panelists. First, we have Apoorva Jadhav, who is joining us from USAID's Bureau for Global Health, where she's a demography and health technical advisor. Apoorva will be providing introductory remarks on today's webinar. As I mentioned, I'm Tess Shiras, a research specialist on the SHOPS Plus project at APT. And then Sarah Bradley is the Global Research Director at SHOPS Plus at APT Associates. And Sarah will be presenting the research methods and findings from our study that I mentioned. Then she'll turn things back over to me to provide some thoughts on implications and share some additional resources before we move on to our question and answer. So with that, I'd like to turn it over to Apoorva for some introductory remarks. Thanks very much. Next slide.
Thank you, Tess. Thank you, Sarah. Hello, everyone. Thank you for joining this presentation today. I know that it's a stressful and busy time for everyone, so thank you, everyone. Next. Source data for many health areas and commodity supply chains are clearly on everyone's mind in light of the COVID-19 pandemic. This brief is particularly timely in that regard. On the demand side, family planning needs will continue despite the pandemic. There may even be more demand, be it for switching to options requiring less physical contact to acquire, or for covert methods for victims of GBV, a huge concern during this lockdown worldwide. But it's the supply side, which is really the most critical in this time of the pandemic, with global disruptions to supply chains, closures of health facilities, limited engagement with community health workers, and fear about visiting facilities that even remain open, to name a few. So this brief informs us about the landscape of private sector sources in various countries, and it honestly couldn't come at a better time. Next. Indeed, the supply side matters a great deal. Just last month, a publication from the Guttmacher Institute shows a hypothetical scenario wherein, assuming a 10% decline in service provision of short and long-acting reversible contraception, there would be an estimated 49 million additional women with unmet need for modern contraception, and about 15 million additional unintended pregnancies over a 12-month period. I won't go into the technicalities of their assumptions or analysis, but suffice it to say, this really underscores the urgency of understanding the supply and subsequent service disruptions and their implications at this time. Next. I'll focus my brief remarks on a bird's eye view of the brief that Tess and Sarah will be presenting and discussing, which you'll all be able to look at online relatively soon. Many of you are familiar with USAID's journey to self-reliance, which is essentially a reorientation of USAID strategies, partnership models, and program practices to achieve greater development outcomes and work toward a time when foreign assistance is no longer necessary. Next. One of the cornerstones to accelerating this journey to self-reliance is private sector engagement, and it ties in really nicely with the crux of this brief and the total market approach. The idea is to enable USAID and host country governments to collaborate with their private sector actors to co-create and co-design market-based and enterprise-led development approaches. USAID's partnership with SHOPS Plus is a really great example, which predates the journey to self-reliance, incidentally, of galvanizing family planning products and services with this public-private partnership. Next. So I want to take a step back and tell you a little bit about the demographic and health surveys, which is really the source of the source data that Sarah and Tess will be talking about today. For those of you who are not familiar, DHS surveys are implemented by ICF. They're nationally representative household surveys, and they're conducted every 5 years or so and have a wealth of information on fertility, mortality, family planning, maternal and child health, nutrition, and so much more. Next. As a member of USAID's DHS management team, I didn't want to miss this chance to share some exciting updates to look forward to in future DHS surveys, once we resume field work, that is, that'll really resonate, I think, with this group. Some of these are related directly to the source data that we're going to be talking about today, and others are on more direct questions related to contraceptives. Next. The previous phase of DHS surveys, so that was between 2013 and 2018, included source categories that were listed as public sector, private medical sector, and other source. Next. But in this newest phase, we have public sector, private medical sector, NGO medical sector as its own, as well as other source. Specifically, within the private sector categories, we have private clinic and hospital that are now standalone, and community health workers are added into the field worker category. Women are asked about where they obtained their method the last time, and they can answer it in a variety of ways, even with the names of country-specific clinics. I know Sarah and Tess worked with country experts to standardize the classification of each source in the categories that they will present, which I can't imagine how much work it took, but it actually includes some of these new categories and is really commendable. Along with improvements in the measurement of source data, we also have improvements in collecting data related to specific methods. For instance, we now have a brand new question on DMPASC with a visual aid, which is really exciting. Women are asked about the last time that they used the method and if they injected it themselves or if a healthcare provider did it for them. There's also now a direct question on sterilization, as well as a direct question on emergency contraception. We also wanted to better capture coitally dependent methods, so added a question to check whether women are deliberately avoiding sex on certain days, using withdrawal, and the like. And we hope this will end up in really better measurement of contraceptive use. Next. The data that we collect and the efforts that we take to make sure that we get it right have tremendous implications. These data are used to plan supply chains, allocate resources based on the location of key populations and their distances to public or private health facilities and so on. So it's really important to contextualize this brief to see how we can advocate for even better measurement of source data and other data in household surveys or HMIS systems, which we know how much countries rely on to get accurate data to take action. Hopefully the addition of the categories I mentioned in the DHS will go a long way, excuse me, but sector misclassifications based on whether women are asked where rather than who provided their service, or lack of awareness of where sources are, if the method was obtained by the partner, may persist, and the brief discusses this in some detail. Finally, it's also important to consider the role of sociopolitical ecosystems. Finally, it's also important to consider the role of sociopolitical ecosystems in countries that contribute to the indicators that we track. So if we take MCPR, for example, which is a core indicator for all of us, we need to really understand the regulatory restrictions or the reproductive health laws, host country commitments to whatever method mixes are available, and the role of organizations in the global north in developing, manufacturing, and supplying new commodities worldwide are critical in really considering how the needle of MCPR changes from survey to survey. I think so often we as a global community seem to focus on the demand side of the indicators. And so I think that this brief will really help us reorient the conversation to provide a more complete picture from the supply side to complement the demand side. And I encourage you to look at the Shops Plus Country briefs for exactly that, which is really much needed perspective rather than just a picture from 30,000 feet. This analysis can help us think about why women choose the sources that they do. It can help us then consider how these choices, preferences, or perceived benefits can impact contraceptive satisfaction or discontinuation rates. And this analysis can also help us tailor the family planning needs in countries based on where they are on their journey to self-reliance and design an approach that suits their context and optimizes the comparative advantages of the public or private sector. With that, thank you. Next. And I won't keep you from the real reason you joined this webinar today. Thank you for listening. Over to you, Sarah and Tess.
Thanks very much, Apoorva. That's a great way to set the stage for today's discussion. And I want to take a minute before we get going with our main presentation today on our findings about where women go for contraception and why it matters, to introduce those of you who aren't familiar with it to our Shops Plus project. Next slide. So SHOP stands for Sustaining Health Outcomes Through the Private Sector. And SHOPS Plus is USAID's flagship initiative in private sector health. The project works across health areas, including contraception, of course, maternal and child health, HIV and TB, to harness the full potential of the private sector and work to catalyze public-private engagement to improve health outcomes. Next slide, please. So as Apoorva noted, now more than ever, understanding contraceptive sources really matter. We have seen a lot of growth in the modern contraceptive prevalence rate, or MCPR, as well as substantial method mix changes, which affects the source patterns that we see. So for that reason, it's important to examine these source patterns on a continual basis to make sure we understand how these changes affect one another. In the context of the COVID-19 pandemic, it is critically important for family planning stakeholders to understand these source patterns so that they are able to work together to create flexible solutions to respond to these new and constantly evolving challenges that we're seeing. More generally, it's very important for government stakeholders, donors, program implementers across sectors to collaborate and understand these sources so that they can work to improve contraceptive access, choice, equity, and ultimately work towards a sustainable contraceptive market. Next slide, please. To guide our analysis, we used a total market approach. A total market approach is a lens for developing strategies that increase access to key health products and services. So in this case, family planning. A total market approach considers all market actors and resources, free, subsidized, commercial, in order to understand the comparative advantages of each sector so that those sectors and stakeholders can complement one another and collaborate rather than compete or duplicate efforts. This lens helps to efficiently target products and services to different population groups in order to improve equity and sustainability. So we've used this lens in order to inform our data interpretation as well as potential implications. So with that, I will turn it over to my colleague, Sarah Bradley, to discuss our research questions, methods, and findings. Over to you, Sarah.
Great. Thank you so much, Tess and Apoorva. And thanks to all of you for bearing with us through a couple of technical glitches this morning with all of us working remotely, as I'm sure you all are. Things got a little discombobulated, but hopefully you can see me and hear me and everything looks okay now. So I'm Sarah Bradley, and I am going to talk us through the methods that we used to answer these and the results from these 5 research questions. So first, we're going to look at time comparisons to see what roles the public and private sectors have played in recent increases in the modern contraceptive prevalence rate. Then we're going to look at the most recent time point only and examine where women now are getting their contraceptive methods and some variations in sources geographically and by contraceptive method. Then we're going to narrow down to look just within the private sector. So where among women who get their contraception from a private sector source, where are they going? Are they going to clinical or non-clinical sources? They're getting their method from a non-governmental or faith-based organization. Then, as Tess mentioned, we are taking a total market approach lens, and to understand the total market, it's really important to understand how different segments of the population are accessing their contraception. So we're going to look at source patterns broken down by some sociodemographic characteristics. And finally, we're going to try to make some generalizations across countries to look at the countries in which the private sector plays a larger or smaller role. So Apoorva did a great job explaining demographic and health surveys. Those are the data that we're using here in all of the countries highlighted in dark blue. We looked at every country that had a demographic and health survey since 2012 that was either a USAID population or reproductive health priority country, a Ouagadougou partnership country, or an FP 2020 country, which gives us a sample of 36 countries shown here. Apoorva also mentioned how important the data is, something near and dear to my own heart. So here are the specific questions that we're analyzing. Women are asked if they're using a contraceptive method, and if they're using something that's classified as a modern method, they're asked where they obtained the method the last time. And we're going to look here specifically at modern methods for which we have source data and enough sample size. So we're going to break down separately pills, condoms, injectables, IUDs, implants, and sterilization. We were asked to present some results that describe not just individual countries, but generalized results across countries. So to do that, we pooled all the data together. So if you can imagine, in our 36 countries all being one big pie, we used DHS survey sampling weights and then multiplied each country by a country-specific factor that made each of those 36 countries kind of 1/36th of this big pie for our pooled results. And I'm happy to talk more about that methodology if people have questions. So when we're looking at results across all countries, that's kind of the average result across the 36 countries, and we do the same thing when we break things down by region. So within the region of Asia, India and Nepal contribute the same to that Asia estimate, even though they're very different population sizes. There are also a couple of exclusions in the data. When we're looking at time comparisons, we took each country that had a survey post-2012, so after FP 2020 partnership was formed, and paired it with a survey that was conducted, as Apurva said, about 5 years earlier on the pre-2012 side. That we weren't able to do that pairing for the 5 countries shown here because they didn't have, for example, Afghanistan, that was their first survey in 2015, and they didn't have an earlier time point, or in Togo, the prior time point was more than 10 years earlier. When we're disaggregating results by marital status, we're excluding this list of countries that only collected family planning information from women who are currently married. And when we're talking about all modern methods, we are not able to talk about lactational amenorrhea method or anything that got categorized in the DHS dataset as other modern, because not all DHS surveys asked about the source for those methods. So as Apurva also mentioned, thank you so much, Apurva, for giving such a great intro. When women answer that question about where they got the method the last time, they can answer in any one of the ways on the right, and those are country specific. They can be very detailed down to the Green Star Clinic. And we worked with country stakeholders to understand, okay, is Green Star a private clinic? Is it an NGO? We then standardize those into the categories shown on the left. And I'm going to use this color coding throughout the rest of the presentation. The private sector is always going to be shown in dark blue, and then later when we break them into these 4 categories in purple. So the private sector gets broken down into private clinical, private pharmacies and drug shops, private general shops or markets, and non-governmental and faith-based organizations. The public sector is always going to be shown in light blue, and there's a small category that's always going to be shown in light gray. That is women who don't know where they got their method, or the majority of this group is made up of women who are using the condom and who said that they got the method from their partner. All right, so I'm going to go into the results now. I can see that people are sending some great questions already, so I'm just going to remind you as we go through, please use the chat feature to send your question to all panelists, and we should have plenty of time at the end for an in-depth Q&A. So first, looking at that first research question, what roles the public and private sectors have played in the recent MCPR increases that we have seen since 2012 in the London Summit. Remember that this looks at 31 countries for which we have 2 time points. And so what we see here are bars that stack to the modern contraceptive prevalence rate among all women, averaged across the countries we analyzed in West and Central Africa, East and Southern Africa, and the Asian countries analyzed. The left bar is the pre-2012 surveys, and the right bar is the post-2012 surveys. And this number on the top represents the total MCPR among all women. And we can see that there's been some really dramatic increases from 8% to 13% in the West and Central African countries analyzed, from about a quarter of women using modern contraception to a third of women in the East and Southern African countries analyzed, and less change in the Asian countries, which started at a higher level. We've color-coded these bars according to the source of that contraception. So dark blue is the private sector, which you can see had small increases in West and Central Africa in the proportion of women accessing modern contraception from private sector sources, from 7 to 9% in East and Southern Africa, 11 to 12% in Asia. But we see a much larger increase, particularly in Sub-Saharan Africa, among women accessing contraception from public sector sources, so 4 to 9% and 17 to 24%. So to understand why we see a different kind of growth pattern between public and private sectors, I'm next going to break this down by contraceptive method. So here we have that same pairing of pre-2012 and post-2012 bars, but now we're breaking this down instead of by region, by contraceptive method. So we can see that there's been, between the pre and post-2012 era, a small increase in percentage of all women who are using condoms. Similarly, that increase in women using pills, a very small change, or really probably no change in IUDs, and a very, very small decrease in the percentage of women who are sterilized. So we see that almost all growth in the MCPR has been through this increase in injectable use and a much larger proportional increase in implant use. And while we see that the private sector, in dark blue, certainly does contribute to use of those methods, the vast majority of that growth has been in public sector provision, because we know that task shifting and task sharing policies and the implant access program has really expanded access to those methods primarily through public sector sources, and that they're really not widely available through private sector sources, which we'll talk about again at the end. So now we're going to look at that second research question. We're looking at among women who are among the current pool of countries, so surveys primarily from 2015 and later, giving us kind of a sense of the current picture across women using contraception in 36 countries, looking at where contraceptive users got their method and how those vary. So on average, across the 36 countries analyzed, 1 out of every 3 modern contraceptive users accesses her method from a private sector source. That varies substantially across regions. So we see higher use in Asia. So 41% of users in Asian countries are getting their method from a private sector source, about a third in West and Central Africa, and about a quarter in the East and Southern African countries studied. There are big regional variations, but even more variation by country. So we see, so these countries are, so each country now is a bar, and this is the percent distribution of current users by where they accessed their contraception the last time. So we can see a really different picture in countries like Indonesia and the Democratic Republic of the Congo at the top of the screen, where the majority of women are getting their method from private sources, down to Rwanda and Timor-Leste at the bottom of the screen, where more than 90% of women are accessing their method from a public source. And I can see some questions rolling in. Hi, Sujan. Please continue to send them as we go. We're now looking at this by method. So part of the explanation for why sources look so different is because method mix is different in each country. So for short-term resupply methods like condoms and pills, we see that the majority of women are getting those methods from private sector sources. So that didn't surprise me when we were doing this analysis, but one thing that kind of did surprise me was that a quarter of women using IUDs, injectables, and sterilization are getting those methods from private sector sources. And we see a much smaller percentage of implant users getting their method from the private sector. So now looking at what that private sector actually looks like, right? So among women who got their contraceptive method from the private sector, where did they go? So this shows, again, the picture on average across those 36 countries. Among women who accessed contraception from private sector sources, 41% of them got it from a pharmacy or drug shop. 11% got them from a general store or a market, which those two together mean that more than half of private sector contraceptive users are getting their method from a non-clinical source. Just over a third are getting their method from a hospital or clinic, and 12% are getting it from a non-governmental or faith-based organization. So that 12% actually really surprised some of our stakeholders when we first presented this. And I'm going to show on the next slide how this breaks down by country, when there's really big variation there again. So again, here we're looking at each country as a bar, and this is just private sector users where they're getting their method. And so dark blue here now represents pharmacies and drug shops. Light blue is also non-clinical, it's shops and markets. Light purple is a hospital or clinic, probably a for-profit, whereas the dark purple is probably also a clinic, but an NGO or FBO. And so one thing to notice here, again, even within the private sector, there's a huge range of where women are going within the private sector across countries. And thinking about that role of the NGO, we see that there's the dark purple bar is very short in many countries, but it is really high in countries like Timor-Leste and Malawi, where the vast majority of women who are accessing private sector contraception are getting it from an NGO. Also, as we would expect, women who are getting their methods from the private sector, the sources that they're using are really different between which method they're using. So almost all pill and condom users are getting their method from a non-clinical source, a pharmacy or drug shop or a shop and market. Almost all implant IUD and sterilization users are getting their method from clinical sources, including a fairly large proportion of private sector implant users getting their method from an NGO. I'm getting a question here. NGOs do operate hospitals and clinics. The distinction is made based on between this light purple hospital and clinic and NGO. They're both considered clinical sources of care, but the light purple is likely to be for-profit, and the dark purple is likely to be non-profit. These were clinics that were identified as, for example, a Red Cross clinic or an NGO clinic or something run by a church or a mosque, for example. Thanks for that question. So one of the things that also really surprised me when I was looking at this, like, okay, this makes sense. We have non-clinical sources for condoms and pills, some for injectables. I was really surprised to see that women are accessing implants and IUDs from pharmacies. So we checked with our counterparts in countries where these were reported and found that in some of these places, women are able to purchase an implant or an IUD from a pharmacy and then bring it to a clinical provider to have it inserted. Now we are looking at our fourth research question. So this is kind of our total market lens again, looking at how source patterns vary by age, marital status, geography, and socioeconomic status. So I'm going to do kind of one spoiler alert here while we're on this page and tell you that private sector use is much higher among contraceptive users who are young, typically the youngest contraceptive users, ages 15 to 19, higher among unmarried women, urban women, and higher socioeconomic status. But then I'm going to get to some slightly more surprising results when we break it down by age and marital status combined. So what I'm showing here is four pie or donut charts. On the left-hand side, there are two pies for women under age 25, and then on the right, women ages 25 and older. The top row is women who are never married, unmarried women, and then the bottom row is married women. So as I said, we found, and we detail this in the full brief, that the youngest women and unmarried women had higher rates of private sector utilization. But when we split them by both age and marital status, we see something really interesting. We see that across age groups, the never married population has almost identical rates of higher private sector use, 47 and 48%. And among unmarried women, only 30% are using the private sector. And that holds true across age categories. So it seems like perhaps marital status rather than age might be the factor driving women to private sector utilization. And that is supported by some literature suggesting that women are willing to use the private sector to ensure confidentiality when we know that in some settings, unmarried sex is really looked down upon. So women may be and married women may be shifted towards the private sector for those reasons. Even though marital status seems to be a big driver, we also wanted to highlight that many adolescents, the majority of adolescents in several countries shown here, are getting their method from private sector sources. That is the majority of 15 to 19-year-olds who are using contraception. And so I showed this result at a conference, and a woman from Nigeria came up to me and said, well, our government works a lot with reaching adolescents, but to reach adolescent contraceptive users, we really need to be working with the private sector. And I said, yep, given that 81% of adolescent contraceptive users in Nigeria are getting their method from a private sector source, to reach adolescents, we absolutely do need to be working with private sector sources. Here we saw that the private sector does play a larger role in urban areas, but we often see that the assumption that the private sector only serves urban areas, but we do see that more than a quarter of contraceptive users in rural areas are also getting their method from the private sector. And I love that I can see these questions because somebody just asked about women's socioeconomic status. Here we go. So when I say poorest here, we're looking at women in the poorest wealth quintile according to the DHS wealth quintiles, which are based on household asset classifications. So we see that among the poorest women, the women in the poorest wealth quintile in each country, 1 out of every 4 of them rely on private sector sources. By contrast, nearly half of the wealthiest women, that is the women in the highest wealth quintile in their country, are relying on public sources. So when we look at this by method, so here again, we're looking at women in the poorest wealth quintile of their country by household on the left-hand side, and the women in the whose households are in the wealthiest quintile in their country on the right-hand side, and this is paired by method. So we're comparing the poorest and wealthiest users of condoms, pills, injectables, IUDs. And so for every comparison, we see that the dark blue bar is longer for the wealthiest women, right? Which is exactly what we would expect. We would expect to see that wealthier women are more likely to pay for contraception or to get it from a private sector source. What's perhaps more surprising is that a large proportion, a third of pill users, 60% of the wealthiest injectable users are still getting that method from public sector sources. So there's a couple of reasons that I think Tess is going to dig into further. So for example, one is that although these wealthiest women are in the wealthiest quintile in their country, that might not mean that they have disposable income to go to a private sector source. There also may not be, for example, injectables and implants available in the private sector in their country. So we really encourage folks to look at this kind of information at the country level, because we really need to take into account the socioeconomic situation in that country and also the policies that regulate access to contraception. And Tess will talk in a couple of minutes about where you can access that information at the country level. So we're getting to our last research question, and we're going to look at, so we talked about the country level, we wanted to see if we could draw generalizations across the types of countries in which the private sector plays a larger or a smaller role. So a priori, we assumed that the private sector was going to play a larger role in countries with higher GNI per capita, right? So countries with higher market development, higher levels of market development, higher socioeconomic status, women potentially having more disposable income to spend on contraception rather than relying on free or subsidized sources. And also that it was going to be higher in countries that had a higher MCPR overall. So women, that is, we thought that that USAID often uses this kind of S-curve analysis, and so that maps countries along where they are in terms of MCPR. And countries that have higher levels of MCPR tend to be focusing more on their journey to self-reliance and sustainability. So we thought that maybe we would see higher private sector utilization in countries with higher MCPRs. So what we did here is, again, this is kind of a matrix. So the left-hand side is countries with lower GNI per capita. So here we just cut those at the distribution of our data in these countries that we examined. So we cut that at 3,000 as gross national income per capita, purchasing power parity adjusted. That's the left-hand side. The right-hand side is countries with higher gross national income per capita. And then the top row is countries with higher MCPR, and we cut that at 20%. So MCPRs of 20% or higher among all women, and then lower MCPR countries in the bottom. So we can see that for our a priori hypothesis, that's kind of true. So women in this high category, or countries in this high category, this is countries like Indonesia and India, where there are large contraceptive markets. 43% of contraceptive users in that pool of countries are accessing modern contraception from private sources. What surprised us, though, is that we also see a slightly higher level of private sector utilization, 34% compared to 28 and 20% in the other buckets, among countries in this low group. So this is lower GNI per capita and lower MCPR. And when we looked at this in detail, we saw that this is countries like the Democratic Republic of the Congo and Afghanistan, where the public sector has some supply issues and the private sector seems to be filling in the gaps. Countries in this bucket, the private sector makes up fewer clinical sources, so it's more reliance on shops and markets. Whereas in this high group, there's a lot more clinical provision. The private sector looks different in these countries. So those are the methods and the results that we found. And now I'm going to turn this back over to Tess to tell us what this all means.
Great, thanks so much, Sarah. So if we move to the next slide, we just presented a lot of information and we want to make sure to distill some of our main takeaways before moving to larger implications. So great. So we saw that 1 in every 3 modern contraceptive users relies on the private sector. And we know that this use of the private sector is even higher among some demographic groups. So for unmarried users, young, urban, and wealthier users, these groups rely even more heavily on the private sector. That said, the private sector is not just the source for the wealthy or the urban. We saw that the private sector is also important for poor and rural users, serving about 1 in 4. And among our private sector clients, more than half go to pharmacies and shops, particularly for condoms and pills. And this is a really important finding in terms of implications on the quality of family planning counseling in those types of private retail outlets, as well as method choice and availability in those outlets. Next slide, please. So there are a number of implications and ways in which our data can be translated into practice. First and foremost, we saw that each country tells a different story. When you saw those graphs that showed the 36 countries, there are really vast differences in each country. So it's very important that findings are interpreted at the country level in tandem with stakeholders who are very familiar with some of these factors that we've listed here. So market development and market shaping, recognition and knowledge of national as well as subnational policies and regulations, governance, including commitments and familiarity with key stakeholders in the government, and then health system capacity and functioning, of course, all play an important role in the source patterns that we've seen. And next, while these data tell us a great deal about where women are accessing contraception, we also need to think about why women obtain a method from a particular source. And we know from the literature that considerations such as privacy, convenience of a particular source, quality or perhaps perceived quality about a source, method availability, and of course cost all play a key role in women's decision making. Next. And so by using a total market approach, these findings can inform efforts to improve method access, choice, and ultimately sustainability as products and services are targeted efficiently to different user groups. And we really want to drive home the point next of the importance of cross-sectoral collaboration. And this collaboration and even just communication in all countries, even those where the private sector currently does not play a huge role in contraception, is really key to achieving universal contraceptive access and choice. We know that women prefer different sources for a variety of reasons. So wherever women are going or want to go, we want to ensure that they're able to access and choose from the full array of methods. So that cross-sectoral collaboration is really key to achieving that goal. Next slide, please. So I want to take a moment to share some of the resources available related to this analysis. As we've mentioned throughout, all of these findings are in our new global brief available on our website. And in addition, we have 21 country briefs for the USAID population and reproductive health countries that have a recent DHS survey. And these briefs are great, like I mentioned before, to assist stakeholders in interpreting the data at a country level. They include more of that country level context. So those are all available at the URL at the bottom of the screen, shopsplusproject.org/sources family planning materials. I'll also share that in the chat. And then we also have 2 interactive data visualization websites under the Shops Plus project. So the first is privatesectorcounts.org. This actually includes all of the data we've shared today, and you're able to use this to assist you in a total market approach and disaggregate the data into all the different user groups, methods, countries that you're interested in looking at. And then finally, we have the FP Market Analyzer, and this tool allows you to take a look at one country and use it to predict future scenarios based on changes in method mix, MCPR, or source. And I'll note this is actually an excellent tool to use right now in light of COVID because you can make your own changes and say, okay, what will happen in the market if this source is no longer available, or the supply chain limits this type of method, and then look at how that will change source patterns and method mix. So with that, we will move to our question and answer phase. We've gotten a lot of great questions, and I encourage you to continue submitting them through the chat feature. So let's see. Our first question came towards the beginning of the presentation. We had someone ask about the big change we've seen in implants pre and post that 2012 time period, and some of the factors that have led to that change. So Sarah, maybe you can answer that.
Sure. Maybe I'll answer, and then Apoorva, if you want to jump in from a USAID perspective. We have seen a huge increase in the use of implants. There's been a lot of emphasis being put on expanding access to LARCs, long-acting reversible contraception, through several channels, especially expanding access for younger women. One of the things that we've seen is the Implant Access Program, which has expanded access at price-controlled levels to primarily public sector sources and also to NGOs. It has not made the implant available in an affordable way, as far as I know, and please, I'm sure we have some experts on here who can jump in, through private sector sources. So that's one of the ways that, one of the reasons that we know that expanded access of implants might be not reaching everybody, especially those unmarried women who seem to prefer going to private sector sources. So yeah, but I will say that this has been a huge success of the family planning program globally that has really expanded access to this really effective method of contraception that works for at least 5 years to women who need it most. And sorry, I'm just seeing Jane's comment about the sustainability of the implant without donor support. That's a really important issue, and part of why we would really like to see price guarantees extended to private sector sources to increase exactly that, to increase sustainability of of access to methods like the contraceptive implant.
Great, thank you. So a question for Apoorva: are there plans to feed back to the DHS ways to improve future measurements related to contraceptive sources?
Thanks for the question. So we undergo revisions to the questionnaire every 5 years. So unfortunately, we've just finished our main revision, and We were hoping to pilot this new questionnaire. We are hoping to pilot this new questionnaire this summer, and subsequent surveys would have the improved source and the contraceptive direct questions in it, but there's no plans currently to add on to the changes that have already taken place. But if there's anything specific that the panel, that the participant is looking for, I'd love to hear it via email, and we can continue this conversation. But officially, the portal is closed.
Great. And I think maybe both of you can take this. Did the study look at the level of satisfaction that women received in either sector? And are there any other information in the DHS or related surveys related to quality?
Great question, and a hugely important one. Maybe I'll talk about some of the work that SHOPS Plus is doing in this area, and then maybe Apurva, you can talk about some of the information that's available from SPA surveys, if that's okay. So the quality issue is of the utmost importance, and we know from the literature that many women say that they prefer to go to the private sector because of perceived higher quality. SHOPS Plus works on this on a couple of different fronts. So we don't have data available on quality directly in the DHS, but we have done several activities to try and measure quality. For example, we work in Nepal with the CRS company, which runs the Sangeeni network of private pharmacies that are able to distribute injectables. And we've done mystery client surveys there to specifically measure the quality of the skills of the service provider, how respectful they were, all of those indicators that we want to make sure we measure. And as a result of that study, CRS has implemented much stronger quality assurance and quality improvement innovations. So I think another way that we can sort of get at this issue is the MII, the Method Information Index. That is a measure of women's reports of how they were counseled the last time they received the contraception. Kind of a longer discussion, but this is tracked in FP 2020 reports. And maybe if people are interested in this, you can email me, and I'm happy to point you to quite a few resources that do their best to measure some aspect of quality from the information that we have in the DHS.
Sarah, and just to add to that last point about the Method Information Index, in the new DHS update, we've actually included a fourth question, because right now it's 3 questions that go into the Method Information Index, and now we've included a question, thanks to researchers at the Pop Council and elsewhere, to include a question on whether you were told that you could switch to another method at the time you were choosing your method. So I think that's going to be a really important addition. The SPA surveys are also part of the DHS suite of surveys. They're the Service Provision Assessment. There is really wonderful data on the availability of contraceptives and supplies at facilities. There's an inventory questionnaire. There's questions on equipment, user fees, counseling. There's exit interviews for clients as well. There's information on provision of STI treatment for family planning clients. So there's a wealth of data in the Service Provision Assessment, but the problem or issue is that they're not as widely done as DHS surveys are for a variety of reasons. I mean, DHS surveys are country-owned, country-led, and so if there's no demand from the countryside, then you don't see the surveys taking place. So the reach is limited of the SPA surveys, sadly, in terms of geography, but the wealth of information, especially related to quality, is huge.
Great, thank you. We have a comment about the fact that private sector mobile outreach often includes IUDs, implants, sometimes even male and female sterilization, but often these services are delivered within a public facility. That, of course, this must be taken into account in analysis, but there's not a great way to disaggregate that. Sarah, do you want to comment on that further?
Sure. As we've noted in the brief and Apurva noted in her comments, the question in the DHS asks where the woman received the method and not who provided it. So we know that there are some examples, for example, through CHAM in Malawi, where private providers are brought in to public sector clinics to provide long-acting reversible contraception like IUDs and implants. And that probably gets reported as public sector, even though the provider herself is from the private sector. And the same thing very well might be happening with mobile clinics. So there is absolutely some degree of measurement error. What we have to do is, the way that we measure is really important, and we have to take into account in our interpretation that women are reporting where they got the method, not who provided it.
We have two questions here about classifying our sources, so related to that. Where are social marketing organizations included? And also the reason that pharmacies are not separated from drug shops.
Sure, thanks. Thanks very much for these questions, and I can see a whole bunch of them that I don't know. If we don't have time to answer all of your questions here, I would love to talk to some of you who clearly have some expertise in this issue, including on the Implant Access Program and social marketing. So hi, Chris, hi, Rian, all of this. So in terms of, I'm sorry, I was distracted by all these questions coming in. Can you repeat the question? Social marketing organizations are referred to as private sector, non-NGO. It's often really hard to distinguish. We don't have information necessarily on products, so we can look at the exact product distributed in terms of pills and condoms. And I'm sorry, the second part of that question?
About the fact that pharmacies and drug shops are categorized together rather than separately.
Yeah, so in most countries that just represents pharmacies. Drug shops are often ADOs, so accredited drug dispensary organizations. Somebody is going to, I'm sure, write in on the chat and correct my memory of that. So the vast majority of those, Denise, are in fact pharmacies, but drug shops in these sectors are, thank you, accredited drug dispensing outlets, thank you, Farhan, are indeed pharmacies.
Great. So the next question is about if we looked at the split within the private sector among youth, both married or unmarried, and if they're more likely to go to a private hospital, an NGO, or maybe a pharmacy or shop.
Yeah, that's a great question, and we do detail this in the brief and also on private sector counts. Unmarried youth or married youth are much more likely to use short-acting methods of contraception. So I think 40% of adolescent users are using condoms, much higher than in any other age group. So they are much more likely to go to pharmacies and drug shops and other non-clinical sources. And whereas older women who are going to the private sector are far more likely to go to clinical sources, whether that is public sector or private sector. And it largely seems to depend on the method they're using. As women get older, they tend to shift on average from short-acting methods to longer-acting methods and sterilization as they end their childbearing and move from spacing methods to permanent methods. If I can, I'd like to answer just a couple of questions that I've seen that have come up on socioeconomic status. One is about marital status. Do women change their marital status, their wealth status when they marry? And so I just wanted to point out the DHS wealth quintiles that we used is based on household assets. So if a woman moves households when she gets married into a household that has more assets, that has a mobile phone, has more secure structures, has an improved toilet system, for example, then yes, she might be placed in a different wealth quintile. But if she moved from, say, her parents' household to her husband's household, and both households had relatively the same level of asset ownership, that would be pretty much the same. I'm also getting some information that in Nepal, pharmacies and drug shops are the same. And then we're getting a really good question here about how regulation affects access through the private sector by country. And Tess, I'm wondering if you might want to try to answer that question, if that's okay.
Sure. So we know that, this is where the situation is different in every single country, but in a number of countries, there are policies, regulations, or guidelines in place that sometimes preclude pharmacies from selling pills unless women have a prescription from a health provider. And in a lot of places, pharmacies are not allowed to sell injectables. So those are some of the key policies in place that often prevent private sector outlets from selling a wider array of methods, but there is advocacy efforts ongoing in many countries as tax sharing and tax shifting guidelines really support the fact that those types of providers can, that injectables should be provided in those types of outlets.
Tess, maybe I can answer. There's a couple of questions that are coming to me privately. Maybe I can answer one of those, and then maybe we can think about tying this to COVID at the end. So I'll just answer this one comment that has come to me, which is a really great one, looking at the importance. So what we've shown here is they're all percentages, right? So we're looking at among the poorest women, the women who are the poorest wealth quintile, what percent are going to private sector sources. But it's also really important to think about the number of women, right? So in many countries, there are a much greater number of women living below the poverty line, for example, than above the poverty line. So for people who are interested, I think it is hugely important information. Please check out our tool, fpmarketanalyzer.org. Again, that's fpmarketanalyzer.org, where you can produce estimates and projections, both based on the percentage of women, but also the estimated number of women, because that tool takes DHS data and combines it with UN population estimates and Track 20 data to produce estimates per the number of women, and breaks it down not just by DHS wealth quintile, which equalizes women into 5 groups across the country, but also by World Bank poverty headcount, so poverty lines.
Great, thank you, Sarah. Yeah, so we just have a minute left. For our final note, it's hard to disconnect anything right now from the COVID-19 pandemic. So each of you could maybe comment on what's going on with the DHS and COVID and surveys moving forward. And in terms of the source information we presented today, how does that relate to the COVID landscape right now?
Great, thanks. Maybe I'll take that and then kick it over to you, Apoorva, for comments on DHS and USAID. I attended recently a webinar in which the director of the Reproductive Health Supplies Coalition spoke about how important it is to understand where women are accessing contraception in the time of COVID, when women's movement has been greatly restricted, when access to contraception has been diminished, and as Apoorva mentioned, that's likely going to result in millions of unwanted pregnancies. And one of the things they spoke about are that we need to rely on private sector supply chains right now, which may be more durable in some senses than public sector supply chains. And also that the WHO and many other guidelines are transitioning to recommending fertility awareness methods, pills and condoms. Right now, methods that don't require contact between a patient and a healthcare provider, right? You can get pills and condoms without touching anyone. Given that the private sector is the primary provider of pills and condoms right now, I think it's really essential that that all sectors continue to collaborate to ensure continued access to as many methods of contraception as possible right now.
Thanks, Sarah. And for the question on the DHS, it's $1 million question. How do you do household surveys and go knocking on doors when there's lockdowns in place? Currently, we have paused field work everywhere, and the ICF team has been really innovative in providing remote technical assistance to whichever phase of survey in countries that's possible for, which has been really great. But again, lockdowns are different based on countries. We just heard that Rwanda lifted their lockdown and they want fieldwork to resume next week. So I'm sort of shrugging. I don't have a great answer. We're hoping that fieldwork can resume in an ethical and safe manner in the next couple of months, but honestly, nobody knows. But we know how important these data are for countries, and so we're hoping we'll be able to, when we do get them, also get them of good quality. Stay tuned.
Great, thank you so much. With that, we'll be closing today's webinar. I want to thank all of our participants for joining today and for a very active Q&A. We will be sending out the recording and slides following the event. Thanks so much.